Purva, shall I start?
Good evening, sir.
Good evening, good evening. So we'll start now. So as usual, I start with a short case first. Can you see my slide?
Yes, sir.
Yes, sir. Yeah, right.
Yes,
Okay,
sir.
fine.
Yes, sir.
Okay.
Good
Okay, good evening. Okay, we'll start with one case now, short case first. This is a story of a 44-year-old man. This 45-year-old man fell down, injuring his head 1 month back. There was no loss of consciousness. Since that time, his wife has noticed that he is walking with head tilt to one side. He has no pain in the neck. So what could be the cause of his head tilt? Since it is following a fall, probably can be neck pain due to some problem in the neck, but he had no pain, maybe due to diplopia. So it can be due to diplopia due to weakness of the cyclovertical muscles. So I asked him whether he has got a diplopia. He said yes. Then he said he had diplopia, but he was not consistent about the position in which the diplopia was maximum. Sometimes he's slightly more on the right side, sometimes the left side, sometimes up. It's totally confusing us. So this is the story. So we cannot localize with the history of diplopia. We have to depend upon the findings in this patient. So the examination extraocular movements. This is the upward and downward movements were normal. He's looking to the left side and looking to the right side. So that is a finding in this patient. Now, what do you think there could be the possibility? Any abnormality seen? I will show the static film state. This is the finding. Or looking to the right side and looking to the left side. You look at the picture and give me an opinion about which muscle could be weak.
Sir, when the patient is looking to the left, it appears that the left eye is not depressing that much, so it can be a left superior oblique.
Okay, but in that case, should have been more evident on looking to the right side, no?
Yeah, yes, sir. That is
Right.
true.
Right. Now look at the right side now. Especially looking to the right side.
Yeah, now it appears that the right eye is depressing more.
Okay.
Yeah.
Or it could be
Or the left
left
eye
eye is
is
up.
depressing. Yeah, yes, sir. Yes.
Perfect. This is the two things. What he said is exactly correct. So it looks as if the right eye is lower or left eye is up. Look into the right side. Okay. Right. Now let us see. So maximum disconjugation is more on looking to the right than on the left side. So which muscle is weak now? Is it right superior rectus or left superior oblique? Both are possible, no? Right superior rectus is weak, that is where the right eye is down. Or superior oblique is weak, that is where the left eye is up.
So we have to confirm by doing the next step.
Okay, very good. So what step will you take now? So this is the answer which you already told. The right eye is down or the left eye is up. So it could be either right superior rectus or left superior oblique. So what test will you do to differentiate the two?
So we have to rotate the head sideways to look at the Madhusudan.
Perfect. You already said it's exactly right. Now let us see the I've rotated here to the left side and the right side. I will show the video. Subsequently, the static picture also I will show. Rotate the left side. Turning the right side, the eyes are almost parallel. There is almost no disconjugation seen on turning to the right side. But turning towards the left side of the head, patient side, there appears to be some disconjugation. So let us show the picture. This is the one. See, on rotate to the right side, I rotate to the left side. Now, which muscle is weak?
Likely the left superior obliques.
Yeah, right. Now here, from this we can say that what will be the problem here? The problem is more when the patient rotates to the left side. That means that either when you rotate the head to the left side, the left eye intorts and right eye extorts. So either of the muscle could be weak. Let us see now. Let us see the findings. The disconjugation is increased on rotating to the left side. On rotating the head to the left side, the left eye intorts and the right extorts. So any other muscle which intorts or any other muscles that extorts the right eye, or any other muscle which intorts the left eye, or any other muscle which extorts the right eye could be at fault. So one of the intorters, that is left superior rectus or superior oblique, is weak, or one of the right extorters could be weak. So here, we have got two muscles in question: right superior rectus and left superior oblique. So here, the right superior does not come into the picture at all when the patient rotates head to the left side. So the culprit is left superior oblique. So you understood what I said?
Yes, sir.
Yeah, you're putting the weak muscle into action. We suspected weak muscle on the left superior oblique or right superior rectus. So we're treating the left side, we are putting the indorter into action. The indorters are superior rectus on the left side and superior oblique. Okay, if either of them will be, there will be more diplopia and more disconjugation. On the other hand, if extrorters are weak on rotating the left side, right extrorters are acting, that muscle is not coming into play. That is the inferior rectus and the inferior oblique on the right side. So those muscles are not in our concern because that is not, we already excluded those muscles initially. Okay, so the question is left superior oblique. So you perfectly said correctly. Now this is problem why I brought this case was because many a time in a vertical, especially in vertical diplopia, patient will not say exactly in which direction it is more or less. Again, the disconjugation may be so subtle that we have to rely on this Wilson's rotation maneuver to find out the abnormal muscle. Now let us see so the left superior oblique. So actually, this patient complained on diplopia. For the discussion's sake, I masked that history. He complained of actually the vertical diplopia and more on looking down. Okay, let us analyze from that angle. How to localize a muscle, but it's cyclovertical muscle, by taking the history of diplopia alone. See, he complains of diplopia and looking down means it's one of the depressor is weak. If the diplopia is more on looking upward, obviously it should have been one of the elevators. So what are the depressors? It could be the inferior rectus or superior oblique of either eye. So it could be right inferior rectus or right superior oblique or left inferior rectus and superior oblique. So any of these muscles could be at fault when somebody complains of diplopia on looking down. That's the first thing. Second, see the eye position looking to the right and left now. The same picture is shown again. See on looking to the right and left side. Again, you find that left eye is up, right eye is down. Okay, that is a maximum separation. So what will be the problem? Disconjugation is more on looking to the right side. So we have excluded those muscles on moving the eye downward on looking to the left side, only on the right side. So which are the two muscles now coming? Again, the same thing. In this position, left eye is up, right eye is down. So it could be left superior oblique or right superior rectus. Because his diplopia is more on looking down, it has to be a superior oblique. So the muscle involved is superior because if it had been a superior rectus, you would have complete diplopia on looking up. Superior rectus is an elevator. So the weak muscle is superior oblique. So even if somebody complains only on diplopia, looking at the disconjugation, looking into which direction, you can still make out which muscle is weak, even without the head rotation. Sometimes people may not give a correct explanation or answer when you turn the head to the right and left side. Okay, is it clear to you now?
Yes.
Yeah, out of the four muscles, we can choose two muscles by ask the patient look to the right and left side. Here, the more disconjugation is more looking to the right side. So those muscles which are moving the eye downward in the leftward direction is excluded. So on looking to the right side, the disconjugated muscle will be either superior rectus in the right side or in left superior oblique. Since he combines diplopia and more looking down, it has to be a depressor. The depressor is inferior superior oblique. If superior rectus was the culprit, it would have complete diplopia on looking up. So that's the answer. Now let us see the history. I have purposely cut off the history of the patient. This is history. I ask him whether the diplopia is maximum. He says he's double now. Now it's a single. He says double. That's a position of diplopia, maximum diplopia. Now you can make out the vertical disconjugation. This is, in fact, this case is a gross case. Sometimes superior oblique pulse may be so subtle, such as severe disconjugation you may not see. So which eye is the same thing, the superior oblique. If right superior rectus is weak, you would have combined deployment no more looking up. And see the head tilt of the patient. He came with the head tilt to the right side, again indicating that left superior oblique is weak. Okay, but the head tilt to the right side does not differentiate between the yoke muscles, superior oblique versus the right inferior rectus. So that alone you cannot depend upon. But when head rotation is seen, tilt is seen, is more of an oblique muscle involvement than a rectus, superior inferior rectus muscle involvement. Although the vertical rectus and the oblique are all called cyclovertical muscle, that means they are both have got torsional action as well as vertical actions. ആദ്യം പൊസിഷൻ ഹെഡ് പൊസിഷൻ ടിൽറ്റ് റൈറ്റ് സൈഡ്. However, this head cannot differentiate between left superior oblique and right inferior rectus. So he was asked to draw how he sees the line. This is how it's drawn. Exactly mimic again. It's a suggestive superior oblique. The arrow is pointing towards the left side. Again, this cannot differentiate left superior oblique, right inferior rectus. You have to resort to the other maneuvers. So any questions in this case?
Sir, what was the cause? Was there any trauma to the
No.
trochlear process?
Yeah, he had a trauma. This developed following a trauma.
Okay, sir.
In fact, superior oblique, one of the most common muscle affected by trauma.
Sir, in some textbooks, they mention that there can be a paradoxical head tilt in case of superior oblique, where the head, instead of rotating to the opposite side, may rotate to the same side in superior oblique weakness. Sir, what is the reason behind it?
I don't know. Rotating to the right side is obvious, no? But rotating to the same side is, I cannot understand. I have not heard of that. Because in paralysis of extraocular muscles, head always turn in the direction of action of the muscle. For example, if my right lateral rectus is affected, I turn the head to the right side. My head is turned to the right side mean either my right lateral rectus or the left medial rectus is affected because it's the direction of action of the muscle. If my superior oblique is affected, the direction of action is what? It's depressor, intortor, and it's an abductor. So what will happen? Right superior oblique affect mean my head will be tilted down. There is a depressor, and it's an intortor. It intorts that turns it to the opposite side and slightly abduct. See, if you look at the action of the muscle, the head will be turned in the direction of that action of the muscle. This is just to make the eye parallel so that to avoid diplopia.
Yes,
Because
sir.
if we turn the other way around, suppose you got lateral rectus weakness to the right side, turn the head to the right, diplopia will not be there. Same principle. So they turn in the direction of action of the muscle. But why it is opposite, I do not.
Sir, one explanation that they gave is that because superior oblique is a depressor in the adducted position, if the patient turns the head towards the right side, the uh, turns the head to the right side, the left eye will elevate, and in that way the patient will rely more on the monocular vision on the opposite eye. So if the degree of diplopia is more, yeah.
That's a sensible explanation. What they in that situation, what happened mean they're trying to suppress the deviated image.
Yes, sir. They're
But turn the head,
suppressing the double image. Yes.
yeah, right. That is only because in chronic stages they take deviate. So ultimately, it help the cortical suppression of the false image can occur if you keep the head on the opposite side. As I said, is correct. That is for the help suppression of the image. But the acute phase always they turn the direction of action of the muscle because that's why it becomes easier for them to do. It avoid diplopia.
Thank you, sir.
Okay. Any other questions? Okay, this is patient normal MRI. So shall I go to the next case?
Yes, sir.
It's a long case. Okay. This is
Sir,
a story with,
performance of
yeah,
the
please,
patient with
pardon?
post-traumatic severe oblique palsy, will it recover, sir?
Yeah, most of them recover. Most of them recover. Without anything, they recover. Sometimes there's in those cases when the trochleus get dislodged because of the trauma, then there sometimes they may require surgical repair. Otherwise, most of them they recover.
Okay, sir.
Because the longest course in the is also the nerve is for the fourth nerve, that is they get damaged in trauma because during the shaking of the brain get affected.
Sir, any role of giving corticosteroids if in the early phase of the disease to hasten?
Yeah, most of them they do give. I also give for a short case, but how for whether it is going to benefit or not, we do not know. Just like diabetic mononeuritis, invariably they recover. Whether you treat or not, they are going to recover within 3 months. Okay, this is a story of a 60-year-old lady. It's a long case. 3 days prior to admission, while she was lying in the bed at night, she noticed burning pain on the right leg below the knee. But 4 hours later, when she got up from bed, she noticed mild weakness on the right leg. Next day morning, weakness progressed, but was still able to walk with support. Next day, on the third day, she was not able to move her right lower limb at all and got admitted. So, story of a 3 day story. Initially, burning pain and and weakness of mild weakness right lower limb. The weakness progressed over the next 48 hours to the extent that she was unable to walk. There is no weakness of the left lower limb or any weakness of upper limbs. There is no pins and needle paresthesia apart from the burning pain she had initially. No root pain, no backache, and no headache. She is not a known diabetic, but found to have diabetes on admission after when she was investigated. She had not checked for a diabetes status before. So this is the video of the patient. The upper limbs were normal. The finest are confined to the lower limb. Left flexion was almost normal. Right flexion is weak, about just 2 plus to 3. Knee extension was also weak, about 4 to 4 plus power, 4 power. Left quadriceps was normal. Left was flexion normal. Right was weak, significantly about 2 to 3 power. Left plantar flexion normal. Right also is almost normal, but it's weak, mildly weak. Knee flexion was also weak. Hip extension was also weak. The abduction on the left side is normal, right side is weak. From the reflex, the upper limbs were normally elicited. Both knee jerks are brisk. Her ankle jerks were absent. Absent on the right side, just elicited from the practically nil, no reflexes. Just a flicker of movement was there, that's all. Plantar was indefinite, mute. Then come to sensation, she had decreased pain on the right lower limb. He said less. Up to the knee, it was decreased on the right side. Vibrations are normal on the left side.
ഇപ്പൊ ഉണ്ടല്ലോ ഇപ്പോഴോ
But decreased on the right side, not absent on the right side.
ഇപ്പോഴോ
Not able to feel.
ഇപ്പോഴോ ഇപ്പോഴോ
Joint sense normal on the left side.
ഇപ്പോഴോ അതേമാതിരി ഈ കാര്യം പറയണം ഇപ്പൊ എങ്ങനെയാ
She could not
അറിഞ്ഞൂടാ
say
ഇപ്പോഴോ
it's up and down.
അല്ല അറിയാം മോളില്
She does
അതുപോലെ
she can see
അതുപോലെ
only
മോളിൽ
movement, but
ഇപ്പോഴോ
does not know what the position it is.
അറിഞ്ഞൂടാ എത്രയും നമ്പർ
Rafa stated it correctly.
കണ്ടടച്ചു ഞാൻ ഏത് കാര്യത്തൊട്ടെന്ന് പറഞ്ഞേ
Then touch also in fact impaired on the right side, so the 2-point discrimination I could not check. She did not say even on single stimulation you should not do
ഞാൻ
not see.
അറിഞ്ഞൂടാ
So every sensation was impaired on the right lobe. This is how she walked, made her walk.
ഇടതുകൈ പൊക്കി അതിന്റെ മറ്റൊരു ഇടതുകൈ പൊക്കി ഇങ്ങനെ പൊക്കിക്ക് അതിന്റെ ഒന്നാണ് നടന്നേ ഇടതുകൈ ഇടത്തോടെ പൊക്കിക്ക് ഇനി മറ്റൊന്ന് പൊക്കിക്ക് മതിയാണ്
The lower limbs tone normal. Power weakness of all muscles the right lower limb. Roughly 3 to 4. More for flexors of the hip, dorsiflexors the ankle and abductors. Power the left lower limb normal. DTR, both knee jacks were brisk bilaterally. Ankle jack absent on the right side, just elicited on the left side, almost absent. Plantar indefinite. Senses impaired pain up to the middle of the right thigh. Not only pain, also touch also. Impaired vibration up to the knee on the right side. Vibration is normal in the left lower limb. JP is impaired on the right lower limb. So these are the findings. So any clarification of the findings before we go to the discussion?
So the planters were mute in this patient?
Mute, indefinite. You saw the point, no response. I could not elicit any either up or down. She's already, she was found to be having diabetes at the time of admission. How long she was diabetic, we do not know.
Any graded pattern, sir?
No grades. No, it is lost only on the right side, and the sensory loss is above up to the thigh.
So the abdominal reflex was done for this patient?
Yeah, that is absent. She's a pateless abdomen, just absent.
Okay. Sir, it looks like a element type of a monoparesis in this patient with both sensory and motor involvement, which follows um, a root pattern as well as a nerve pattern, sir, not fitting with both. It may be a diabetic plexopathy because the patient started with pain, with, sir, some component of a neuralgic amyotrophy, which is causing weakness of both the proximal and the distal parts. Sir.
That is what normally, exactly what is I should consider, because patients got loss of pain, touch, as well as posterior column, all on the same side, the lower limb, with weakness affecting the proximal distal muscles, whole pan plexopathy on the right side. But is there anything odd to diagnose that possibility?
So both
Knee
knee
jerk is
jerks were
brisk, sir.
brisk.
Yeah, knee jerk is brisk, that's a
Yes,
problem.
sir.
And that's a problem.
Sir, but in early plexopathy, jerks may be preserved.
No, usually the thing is with the significant weakness, with the not even normal, it's slightly brisk reflexes. Even the upper limb fluids are also sluggish, just elicitable. So that's a little odd. Otherwise, the localization, if we take everything under the plexopathy, is a good possibility, except for the brisk knee jerk. And that too, knee jerk is brisk bilaterally also. Any other thoughts?
So there was no history of bladder involvement in this patient.
No bladder involvement. History is not there. This application is predominantly one side, no? Even if it's a cord lesion, one may not get it.
Cerebral lesion.
Pardon?
Brain.
Cerebral lesion. Yeah, that's another
Yeah,
thing we have to
cerebral
strongly
lesion.
Yeah, always when patient come with unilateral lower limb weakness, cerebral lesion is a good point because that is another side where the patient has got lost or every sensation lost on one side. Okay, let us discuss this particular point at this point of time. So one thing one should consider is because of this knee jerk, whether it's a thoracic cord lesion on the right side. The right angle jerk could have been absent due to associated peripheral neuropathy the patient had. There are odd points for that. So then the question comes, if it's a thoracic cord lesion, how to explain the pain in posterior column sensory loss on the same side? Difficult to explain. Okay, you expect a Brown-Séquard cord syndrome. So you get a pain loss on the opposite side. So thoracic cord lesion is very unlikely. Whether it's a cortical or a left thalamocapsular lesion, that's another possibility which you have to keep because that's a situation where you can have all sensory loss on the opposite side. Less likely to be cortical. Why less likely to be cortical? Because in cortical lesions, usually the vibration is preserved. So why the vibration is preserved means he has got the vibration is appreciated at the level of thalamus. So also they don't have a pain loss. They can have some pain, they complain of pain. Pain loss is also very unusual for a cortical lesion because they are appreciated at the level of thalamus. So impaired vibration pain is very uncommon cortical lesion. But however, in acute cortical lesions, it has been mentioned they can be lost, but usually as days pass by, they recover fast. So let us analyze the problem one by one. Now, the first thing is that, you have got weakness of the right lower limb. The first step is it element human? That is the first step. No, if you still do not know whether it's element human. There are some features of human, some features of element. Both cannot be go together. Let us see. If it is human, why should we consider human? Because the right knee jerk is brisk in the presence of a weak corticeps. The corticeps muscle is not affected. The reflex is still brisk. You can say, oh, that's not a weak muscle. You can be ignored. But a weak muscle with brisk reflex, we have to always consider the possibility of a pyramidal lesion. The absent angle jerk could have been due to the undetected diabetes since it is absent on both sides. That way you can explain the absent angle jerk with a pyramidal lesion.
Equivocal plunder.
Pardon? Equivocal plunder, equivocal. Yeah, that is. Now, if it is element, how do you explain the element lesion? An epiconus lesion extending from the L2 to S1 on the right side, yes, possible. But again, you can explain everything by extensive lesion in, say, intramedullary lesion. But again, difficult to explain the wrist knee jerk. Okay, the right side. With extensive lesion, intramedullary lesion, cutting the crossing fibers, causing the pain fibers and the touch fibers, and then the element weakness. But again, little odd. That's why difficult to explain the loss of pain posterior column on the same side, but it can be explained by a long intramedullary lesion cutting the crossing spinothalamic fibers right side. Okay, that way you can explain. Or a chordaequine lesion on the right side. These are the two possibilities where both can be lost. This can explain the loss of pain in posterior column on the right side. But again, these lesions are difficult to explain the knee jerk on the right side. Even explained by a long extensive lesion, you cannot explain by knee jerk. Unless you think of it, there is a lesion in the pyramidal tract above the epiconus. That's why you can explain. Now, next problem is an epiconus lesion. The knee jerk can be explained with associated pyramidal affection. That means an intermediate lesion causing the pain loss on the right half and the right lower limb is also affected the pyramidal tract and the lateral column. Okay. Is that possible? Epiconus lesion on the right side causing obvious posterior column can be affected on the same side. You can have pyramidal weakness on the same side. Can produce loss of pain also on the same side?
No, sir. Crossed spinal
Yeah,
thalamic.
yeah, right. That come to that. So that's what I will explain that later on. Okay, what investigation you do now? So I pose the various problems to you. Difficult explained by an epiconus lesion. Difficult explained by a thoracic cord lesion. Difficult explained by a cortical lesion. Chordaequine obviously is unlikely because all I mentioned all the odd points.
The NCS first.
Okay. And in fact, one of the possibility considering whether could be stroke was present acutely. A CT scan was done. CT scan was normal. So what next? So MRI brain was also done. This is MRI. There is no lesion in the MRI to explain the weakness. Now let us see one more point which we all missed is look at the gait of the patient. Looking at the gait, do you think the lesion is confined only to the right lower limb?
There's a steppage gait of involving bilateral posterior column involvement should be there, sir.
Actually, it's not a step. She's dragging the feet. I will show the video once again. She's dragging both the sides. See the way she walks. The way she put forward means either inflection is weak or spasticity is weak. She's not bending the knee. Both knees is keeping it extended. So that was more like a spastic gait or like a pyramidal lesion, or you can explain by hip flexion weakness. In the presence of a brisk knee jack, that means most likely to be pyramidal. Okay, let us see. Coming back to our discussion now. This is the gait I. The video shows difficulty in pushing her both the lower limbs forward due to whether that is due to the weakness of flexes bilaterally or associated spasticity, more likely lateral with a brisk knee jack. So that most likely is got a pyramidal lesion. So I did NCA studies, as somebody said, because then associated angle jacks were absent. To explain the absent angle jack would associate peripheral neuropathy, it's found to be normal. There was no peripheral neuropathy at all. Then what else do you need now?
MRI lumbar.
MRI lumbar. Okay. MRI thoracic spine, what is the lumbar? This is the dorsal spine. The lesion has to be, even hip flexors are also weak. No, it has to be above L1. That means it comes to the lower dorsal region. Okay, that's the story. So we could not localize where the lesion is at this present time. Okay. Let us move on. On the second day, she complained of mild weakness in the left leg. This is a second day finding. Usually weakness in the lip flexion. The hip abductor is normal initially as weak. However, dorsiflexion was normal. Plantar was also normal. Normally affecting the proximal muscle. The knee jack, which is brisk initially, has become absent. That is elicited on the left side. But still, less compared to that. Plantar is again mute. Sensory is same as before. It is more on the left side. APS was impaired just like before. Okay, so new findings on the second day. Moderate weakness of the left hip flexors and mild weakness of the hip abductors. Distal muscles appeared normal. DTR right knee jack, which is brisk earlier, has become absent. Left knee jack was less compared to the first day. Both angle jacks remain the same, absent. Sensory findings remain the same. Now, Now, what do you think?
It looks more like an evolving element syndrome than UMN one, sir.
Exactly. It's the molecular element syndrome. Correct. So, where is the site of lesion now?
Sir, if the NCS is entirely normal, then it has to be.
Normal. NCS is normal.
So
But
it
that is
can
done
be a.
on the 5th day.
So we have to repeat NCS, and if it is still normal, we have to consider a preganglionic lesion, sir.
Cauda lesion.
Yes, sir.
But the only thing is that lesion has gone above L1. Hip flexor is also weak. Cauda will not likely to produce hip flexion weakness. So, any other thought?
Flexopathy.
But
Bilateral.
bilateral, no, it is.
Bilateral.
Okay. Yeah, right pan flexopathy and left proximal agreed. That's a possibility which cannot agree rule out entirely. It's a possibility. Little odd, no, it has come immediately after the third day developed on the left side. And she never complained of pain on the left side also. Initially, she had only not the classical pain, but burning pain on the right leg she was complaining. Okay, let us see. See, now the question comes as the pre-doctor says, I ideally thought could be cauda equina or epiconus. The same can occur in epiconus lesion also. Because cauda equina roots are arising in the epiconus. Those roots, that way you can explain the hip flexion also. So on the 4th day, let us see what happened. The 4th day, the weakness has become more prominent now. It has become 0. The left ovary proximus weakness has become worse. But distal muscle was not affected. The reflexes became smooth knee jack became absent. Angular also already absent. Sensory findings remains the same. And again, sensory findings same as before. In the interest of time, I'll pass forward. Okay. Lower limb power weakness of all muscle right over limb is worsened. Grade 1 to 2 in the proximal muscles, grade 0 to 1 in the distal muscles. However, the left lower limb weakness, the left hip flexors, knee extensors has worsened, but the distal muscle has not worsened. Knee jack and ankle jack absent bilateral. Sensory findings remain the same. Now, what do you want to do now?
Repeat NCS.
Repeat the NCS.
Repeat NCS. Okay. This MRI was repeated actually. This is the MRI. It's got hyperintensity in the lower spinal cord, spanning from D10 downward. Corresponding to the epiconus region. Coming down. Then you can see the hyperintensity. Little more beyond the epiconus also. Hyperintensity going up to the lower dorsal spine.
Cord enlargement.
There's the enlargement of the cord also. This is axial cut showing the hyperintensity within the epiconus. More profound onto the right side than the left side. Right half of the cord is affected. See, the right side is affected. These D10, D11. D11. Now let us see, come back and how to explain everything together in this patient with the present hyperintensity. Now this will answer, I will answer the previous doctor's question. How can an epiconus lesion produce pain loss on the same side? In fact, a lesion might have affected the lower dorsal cord at about D2 L1 level, more on the right side. Okay, I'll come to that. So due to the action, what had happened? She had bilateral pyramidal involvement. Why? Because he has got a brisk knee jack. Right side pyramidal tract is more affected. That is why the right lower limb has become weak. Then this can explain the brisk knee jack bilaterally because of the pyramidal involvement, which is more on the right side. Can also explain the pyramidal tract on the right side, sorry, posterior cord on the right side. Again, right half of the cord is affected. The decreased pain loss on the right side could be due to the involvement of the ungrossed spinothalamic fibers, which take long standing course in the lumbar cord. I will explain that thing. See, the classical Brown-Séquard syndrome will not be seen in lesions in the lumbar cord. Because as you know, the pain fibers that enters the spinal cord ascend for few segments before crossing to the opposite side in the tract of lesion. This slant, the ascent, is least in the lower dorsal cord at the D2 level. As the spinal segments go up, the slant becomes more and more. So it will be lately maximum in the upper cervical cord, where the lesion, suppose lesion is at C1, the sensory loss may be at C4, C5 level. But the maximum slant is actually in the lumbar cord. That is the pain fibers which enter the lumbar segment do not reach the opposite side unless it has reached almost the L1 level. Because that ascent is maximum in the lumbar region. So in such a situation, what happened means the fibers has not reached the opposite side. It's still on the same side. So you can loss of pain on the same side. So this point I already mentioned some time back in a person who had a bupivacaine-induced lesion on the right side of the cord, where the patient had loss of pain and posterior everything on the same side. So this is the point I'm trying to tell you again. Hemichord lesion need not always produce Brown-Séquard syndrome. See, this is the test book from the Bing's test book. See, this is how the fibers are going. They are ascending, the slant is maximum in the lumbar cord. So lesion here is going to cut off the pain fibers all on the same side. It has become a track, almost most of them are reached the opposite only by about L1 or L2 level. So you can have a lesion on the same side, the right epicornus region. This can involve loss of pain on the same side, not because of the spinothalamic tract is getting involved, but because of the crossing fibers, ascending fibers are in. Which unlike in other segments, it's not one or two segments, multiple segments you take for the treat the opposite side. That is how you can, so individual segments lie so close together so that few crossing spinothalamic fibers passing caudal to the lesion reach the opposite side. The slant of the ascending spinothalamic is maximum in the lumbar cord. Now let us see the other aspects. So we can explain everything by a lesion of the spinal cord at say D12 L1 level, affecting the both pyramidal tract as well as posterior column and the spinothalamic tract before it tosses. Now, as disease progresses, what happened? The lesion extended down, affecting more lower and lower segments. So from D2 L1 level, it has now come to L2, L3, L4 level, becoming that is why initially knee jerk became brisk, subsequently knee jerk became lost. Because the lesion has come down, involved producing element weakness at the epicornus, resulting in loss of knee jerk, which were brisk bilaterally initially. The initial weakness of the distal muscle right lower limb could have been due to the initial pyramidal lesion itself. However, the possibility of a long intermediary lesion on the right half of the epicornus region with associated pyramidal lesion cannot be told. I will explain that later on. So this is one explanation. That what I'm trying to postulate is like this. The patient had initially a lesion at L1, L2 level like this, affecting both pyramidal tract more on the right side. Okay. Then the lesion might have extended down along the epicornus, involving the anterior horn cells of the L2 to L5 segment, causing lower motor neuron type of weakness. Coming to the epicornus and produce element weakness. That can explain the whole scenario in this patient. Or the second explanation is that from the very beginning itself, Patient might have been having bilateral pyramidal affection at L1, L2 level, same as before, causing the brisk knee jerk and possibly bilateral spasticity. At the same time, the lesion was extending along the gray column longitudinally on the right side, causing the pain loss, cutting of the crossing fibers. When the lesion in the gray column started affecting the anterior horn cells on the right side, and then the left side of the L2-3 level, patient knee jerk on both sides become lost. And he developed worsening of the right cortices weakness and new element weakness of thigh muscles on the left side. So this is second explanation like this. Initially, the initial lesion is same, but subsequently what had happened, it has came down on towards the right side, cutting of the pain fibers on the right side, crossing fibers. That's other explanation. The two ways you can explain in this patient. If this is a situation, I explained how the pain can be lost in an epiconus lesion on one side lesion alone because of the involvement in the slanting fibers before it crossing. Or it can be due to the crossing fibers inside the cord, like this. But in that situation, the lesion has to be longitudinally extensive lesion because you have to cut off all segments. The crossing fibers to be cut off to produce pain loss on the right side. Just like you get in syringomyelia, you get pain loss on the right, whole of the right upper limb. Because the lesion is all cutting the crossing fibers. So this is story. So any questions regarding the explanation? Any clarification?
So will examination of the perianal sensation help in any way in this patient?
No, because
Because
no, in fact, I did not do that because the lesion I initially also was thinking of in a brisk reflexes with weakness or a pyramidal lesion. That's the thing initially we had considered. But subsequent evolution made it think this LML lesion is developing. So how to explain with a pyramidal subsequent LML, the only way is that lesion is descending down, cutting off the element, producing element weakness.
Sir, one doubt, sir. So the
Yeah,
initial
please.
absence of bilateral ankle reflex might be due to the
It-
pre-existing diabetic status itself, sir.
Yeah,
Because
that is difficult to explain because of the maybe associated peripheral neuropathy. That is the thing we can explain. Otherwise, you cannot explain the, as you said perfectly right, initial lesion occupying there, descending down should not have involved the angle jack initially. That is why I brought down the second explanation. That is lesion initially might have been also be then longitudinally there, but the maximum trend was in the pyramidal tract initially. The element lesion was mild. Subsequently, the lesion is increased and producing the element weakness more prominent, masking the pyramidal signs. Once the element develop, we can develop, when you develop, pyramidal signs will go off.
so why not the bladder was involved, sir? Because it was a bilateral
So it is,
lesion.
if you look at the lesion, see, the intramedullary lesion is mainly from D12 to L4 only, because that's the area where the bilateral lesion is affecting both anterior cells. The left distal muscles are still normal, power is gate 5, even on the day 4. So that cannot occur with the pyramidal lesion. That's an element lesion. That is why the lesion, even though it is bilaterally suffered in the central gray column to produce the element weakness, not the bilateral pyramidal tract. Maybe am I made it clear to you? Because that is, suppose it's a pyramidal tract is affected bilaterally, then it should produce distal muscle weakness left lower limb as well. But that was not affected. Telling you that the possible involvement of both the lower limb is element. Initially might have been brisk reflex, okay. Now it is element. Because why this lesion is intramedullary inside the gray column.
So predominantly the lesion affects only the gray matter of the cord, sir.
Right, gray matter of the cord in the L2 to L4 segment. The rest, right distal muscle weakness, whether it is UMN, whether it is LMN, it's difficult to say. But the lesion the L3 fold is LMN. Initially, there was a pyramidal lesion above, why the reflex has become brisk and spasticity, but subsequently lesion has descended down to the L2 to L4 segment, the anterior constant, That means the pyramidal signs have disappeared, element become more dominant. The opposite leg has become better by element weakness.
Yes, sir.
If it is pyramidal node, naturally we expect a lower disturbance also to be involved. No?
Yes, sir. Yes.
So the course of the hospital sees showed mild elevation of protein cytosis. Anti-MOG was not done. It was because it was not available at that time. It's a case seen long ago. Patients put on IV methylprednisolone and the weakness improved to normalcy over a period of 2 months. Now she was followed up after 1 year here for follow-up. This is the time. Upper limbs are all normal. Lower limbs go to the lower limb binding. Lower limb still spastic. The element findings have improved. Pyramidal underlying pyramidal senses become evident.
ഷൗട്ടിങ് തള്ളു മാറ്റി അത് തന്നെ അതേപോലെ തള്ളി അങ്ങ് മാറ്റി മാറ്റി വെരി ഗുഡ് അത് പിടിച്ചു ബലത്തി പിടിക്കും ഇവിടെ അകത്ത് പോലത്തെ പിടിച്ചേ പൊക്കി പിടി ഇത് പൊക്കി പിടിച്ചേ ചവിട്ടിന്റെ കയ്യിൽ ചവിട്ടിപ്പിടി ഇനി ചവിട്ട് ഇനി അത് തന്നെ ഇനി ചേർത്ത് വെച്ചമ്മ ചേർത്ത് പോയി അകത്താ സംഭവിക്കും മതി വിട്ടോ മതി.
Now let's look at the reflexes now in the lower limb. Become brisk now. So the initially individual patient had even the right angle jack is still absent. Left angle jack is become brisk.
കൊടുക്കില്ലേ അറിയാവോ ഇതൊക്കെ ഒരേപോലെ അറിയാവോ
The pain loss is improved.
ഇതും ഇതൊക്കെ അറിയാലോ
അത്ര ഇല്ല
He says still it is less, but it is better than before.
അത്ര ഇല്ല
ദിവസമാക്കിയില്ലേ ഇപ്പൊ എങ്ങനെയാ അറിഞ്ഞോടെങ്കിൽ അറിഞ്ഞോടെന്ന് പറഞ്ഞു
That is still in pain.
അതുപോലെ
APS is in pain. That is normal. That postural sensory loss is not totally improved. She is now able to walk without any problem, except for the mild dragging of the right lobe.
എല്ലാ ദിവസവും ഇല്ല, ചില ദിവസങ്ങളിലൊക്കെയാണ് ഞാൻ
Spastic bilaterally, patients become power has become normal, except for the right angle. Bilateral pyramidal lesion, both sides of the long LM lesion was masking the pyramidal signs. Okay, any questions?
So you might have put the patient on IVMP on the first day itself, sir, or only on the follow-up day, sir?
Well, after the MRI, after seeing the hyperintensity, put her on IVMP. Till that time, I was not sure what the patient was having.
Follow-up MRI, sir?
Pardon? Follow-up MRI, I did not take. When she has become normal, I did not take.
Okay, sir.
Okay. Any questions? Or we can go to the next case. Okay, shall I go to the next? Yeah, right. So one more case. This is a story of a 34-year-old man. He noticed difficulty in getting up from sitting position from the age of 10 years. Difficulty in climbing stairs for the last 4 years. Difficulty elevating both arms for the last 4 years. No sensory complaints. No complaints referable to the cranial nerve dysfunction, cranial function. So difficulty in getting up squatting position, sitting position from the age of 10 years, that is about 25 years duration. Difficulty in climbing stairs for the last 4 years. Difficulty elevating the arm for the last 4 years. Very slowly progressive condition. He was born of non-consanguineous marriage, no positive family history. He was detected to have hypothyroidism 3 years back and was on L-toxin since then, with which his weakness has partially improved. Presently, he is on L-toxin 100 microgram daily. So this is the findings now. Both deltoids were weak. Mild wasting of the deltoid is seen, deltoid and biceps. Biceps was weak. Biceps is normal power. Brachioradius is weak. Wrist extension was normal. Finger flex is normal. Small muscle normal.
Keep it like that.
Beaver sign was negative. Hip flexion was weak bilaterally.
Keep it like that.
Knee extension was also weak bilaterally. Thigh abduction was good, but thigh adduction was markedly weak. Hip extension was also weak bilaterally. It's got hypertrophy of the ADP. Consider hypertrophy of the ADP there. Dorsiflexion power was normal at bedside examination. Plantar pressure also normal. Reflexes upper limb flex was just elicitable, sluggish, 1 plus. Triceps was elicitable. Biceps was supinated were almost absent. That's just elicitable. Abdominal plus intact. Both knee jacks were absent. Ankle jack well elicitable. Plantar flexor. Sensations are all normal. Look at the gait of the patient. But abdomen is protruding, but that means it's got an excited lumbar lordosis. It's got a mild waddle. He could not get up from the sitting position in this position. Adductor position not at all possible. He could not get up. But the thighs are abducted. He could get up. He's also got hip extension weakness. He could not stand on heel, but he could stand on toes. And Trendelenburg test was positive, more marked weakness on the left side. The right hip is sagging down. There is no bringing of the scapula or any weakness of the serratus basis. Okay. So on examination, canines are all normal. Upper limbs, mild wasting of both deltoid and biceps. Power, shoulder shrugging normal. Weakness of both deltoid, biceps and brachioradialis. Triceps, wrist and finger muscles normal. No scapular bending, no weakness of the trapezius and serratus anterior. Lower limb, hypertrophy of the ADP. Power, hip flexion, hip extension weak. Hip abduction and abduction very weak. In fact, adductors are markedly weak compared to abduction. The abduction weakness I could not elicit at the bedside. Only on Trendelenburg test, the abduction weakness became prominent. Dorsiflex were mildly weak. He could not stand on heel, but could stand on toes. Plantar flexion normal. He could not get up from stool with thigh adducted, but get up when the thighs are abducted. What is this sign called as?
Abductors playing signs.
Abductors playing sign. Very good. So no beaver sign. DTR, both biceps supinate are absent. Triceps just elicitable. Both knee jack absent, ankle jack present. Plantar flexor sensation. And patient could not stand on heel, but could stand on toes. Trendelenburg is positive bilaterally, more weakness on the left side. Gait walks with mild waddle with accelerated lumbar lordosis. Could not get up from stool with thigh adducted. So what is the likely diagnosis in this patient?
So there is selectivity among the muscle fibers which are both in the shoulder and the pelvic girdle, with the
Right.
selective involvement of the hip adductors maximum. So a likely case of a limb girdle pattern of a myopathy, dysphallopathy may be considered in this patient, sir.
No, the classical, what you said is correct. The important diagnostic clue is the thigh abduction sign,
Yes.
right? Adductors are more weak.
Calpainopathy.
Okay, calpainopathy is one possibility. But usually calpainopathy characteristic finding is it's got a scapular
Scapular
winging.
is
Scapula much affected and they put a contracture is another important finding. They can have abdominal involvement, but these are the key findings.
So when the problem started, sir? 10
It
years.
is start at the age of 10 years.
Man, when he was 10 years age.
Yeah, but the calpainopathy is more progressive, no?
No. I'm just asking this problem started when the person was at the age of 10.
10, correct.
So when it was started at the age of 10, and it was very slowly progressing.
Exactly. Very slowly
progressing. But predominantly involvement looks like proximal muscles are more affected than that of the distal.
Distal also is affected, dorsiflexion is affected. So mainly proximal, but this is
So it's likely to be a congenital type of myopathy. Now, very slowly.
But he was already till 10 years of age.
Yes, sir, but there is predominantly weakness of the adductors, and abductors are comparatively spared in the lower limb.
Yeah, but that pattern is described in certain condition. One is calpainopathy, other condition is
Without any
sarcoidosis.
swinging, without any winging on the upper limb involvement,
Yeah,
calpainopathy.
that is described as sarcoglycanopathy.
Yeah, most likely with sarcoglycanopathy.
Yeah, that's the thing.
And we also cannot consider FSH because the Beaver sign is also negative.
Native and face is not affected, and the pattern is not like a facial scapular musculitis.
Yeah, so this is most likely to be a congenital myopathy, any type of group. We have to fit it, whether it is a myofibrillar or it is an line. These types of things we have to think about.
Okay, so I thought more like a sarcoglycanopathy in this patient. Anyway,
The
let
history
us
of
see.
myotonia, sir.
Is there?
History of myotonia was there.
No myotonia.
He
So
had
what about the
frontal
truncal muscle involvement in this patient, sir?
Truncal muscle was weak because he's got a protuberant truncal muscle mean he has got he could not get up from the lying down position easily. The tongue muscle is also weak.
Sir, any stiff spine like syndrome like in myofibrillar we get a stiff spine?
That's what do you call this in SPN type of myopathy, where there is rigid spine syndrome. That's not the presentation here. He had no stiffness like that. There is a contracture in the truncal muscles where he cannot bend. That is not seen here. So I think at this level we can say it's a myopathy because and the myopathy itself more like a dystrophy in view of the selective effects of the muscles and hypertrophy of the ADB. So we know some kind of a muscular dystrophy is likely possibility or a congenital myopathy, but more likely muscular dystrophy. So which muscular dystrophy? So thigh abduction sign. Now before that, what causes the thigh abduction sign?
weakness of the hip adductors will cause the access. I mean, they will use abductors to get up from the squatting position, sir.
See, when you get up from the sitting position, you are getting it with the help of quadriceps and hip extensors. The abductor is nothing to do with, but why is the limb goes into abduction? That's the question.
Because the adductors are weak.
Pardon?
Adductors are grossly weak, sir. That's why he's going there.
Yeah, correct. My question, you're perfectly right. So that's why the thigh goes into abduction because when you stabilize the pelvis, both muscles contract together, adductors and adductors. When it is weak, thigh goes into abduction. But did you notice the one thing which I have shown before? He is able to get up when the thighs are abducted.
Yes, sir.
I'll show that thing.
Sir, he is using his truncal extensors to get up.
See, I'll show that. Before that, just before that, one more point. Okay.
Sure. Right.
The other guy could not get up. When he's abducting it, he could get up. I was also finding it difficult to explain how that can occur in this patient. Obviously, it is in the mechanics of getting up is facilitated when the hip is abducted. But anyway, this is a sign which you have to keep in mind, indicating a profound adductor weakness. Okay, this is described in two conditions, kalpinopathy and well as this is the explanation. In healthy individual, hip abductors and adductors work together to stabilize the hip joint and control leg movement during activities like standing up. When there is weakness in hip abductors are not strong enough to counteract the force of abductors, leading the legs to move outward abducting. Since iliopsoas muscle is oriented in the medial position of the spine, that's not required. That's not important. So, which muscular dystrophy? That's the question. So, what test you need?
Genetics, sir.
MRI muscle.
MRI the muscle. So, MRI muscle, CPK was 456, not grossly elevated. Usually, circular can be elevated, we expect elevated CPK.
Yes.
TPO is normal, TSH was normal. So, MRI was done. It was surprisingly, all the muscles were got fatty infiltration. I'll show the MRI. See, this is the posterior compartment as well as the corticeps are all got a fatty infiltration. I will show the picture of this muscle later on. Then look at the paraspinal muscles, gluteae. They're all hyperintense. Then the iliopsoas muscle, also hyperintense. Fatty infiltration. That is iliacus. Again, the paraspinal muscles were also hyperintense. The scapular muscles are also deltoid. Infrasuprarenal spinals are also hyperintense. Fatty infiltration. So in fact, most of the muscles are affected. Now, this just to recollect the normal anatomy of the muscles for because we do not usually look into these things. This is the vastus lat, the thigh, the horizontal section of the thigh muscle, showing the anatomy, radial anatomy. That is the vastus lateralis. That is the rectus femoris. That is the vastus intermedius. That is the sartorius. Now look at our patient now. This is our patient's thigh. Compare with the normal anatomy here. There is a gracilis which is not affected much. Adductor longus is affected. Adductor magnus is severely affected and atrophied. And semimembranosus is severely affected. And biceps also affected. Semitendinous less affected. And the cortices obviously, except for the rectus femoris, all of the muscles have got a fatty infiltration. This is the leg of the patient. MRI the leg. Again, I will show the normal anatomy later on. This picture is from another patient, just to show the anatomy. This is a tibialis anterior, which is affected in that particular patient. This is not our patient. There's the extensor digitorum longus and brevis. That is the location of that muscle. Peroneus longus is that one. Then soleus is a large muscle posteriorly. The outermost is the gastrocnemius. That's a tibialis posterior, which is inside the soleus. This is our patient. Look at our patient now. The tibialis end is also affected with fatty infiltration. Extensor digitorum longus is also affected. Peroneae are not that affected, less affected. And soleus is affected. Gastroc is also affected. So this is the report of the radiologist. Features sensitive of muscular possibility, scalp pain, limbical muscular dystrophy, and myofibrillar myopathy. This is the report given by the radiologist. So what do you want now?
Genetics.
So I did a genetics test, but this came as something different. I don't know. They say, see, this RYR1 myopathy, they told. And they are likely pathogenic, but it's the OIM type is congenital myopathy, 1B autosomal recessive. I do not know what it is. And the test result interpreted homozygous likely pathogenic variant consistent with the phenotype detected. So the other condition which can produce sleep addiction weakness is a myofibrillar myopathy. This also you keep in mind. So I'll skip all those things. This is about the R1R myopathy. It's a group of genetic muscle disorders caused by mutation in RYR gene, which encodes the protein crucial for muscle contraction. These disorders are characterized by muscle weakness and can be associated with myelin hyperthermia. This is often symmetrical and can be more pronounced in the muscles closest to the torso, that's postural muscles. They can have facial muscle weakness, eye muscles can be affected, bulbar muscle can be affected, delayed motor milestone in infants and children, hypertonia and redness. So our patient's clinical picture does not fit in with that, but the genetic test has come like that. So I think I should have, there are other tests for diagnosing calpainopathy and sarcoplasmopathy, but I do not know much about that. So I only did a genetic test to find out this thing. This is the result desk.
Sir, there is a stark clinico-radiological discordance even in the muscles which are spared.
Right.
We are getting severe.
Exactly. Yeah, right, exactly. That means it's a very, very slowly progressive disease affecting all the muscles, still not much of a disability for the patient.
Will muscle biopsy help?
We should have done a muscle biopsy. Patient is not here now. I think we should have muscle biopsy and histochemistry, some other things has to be done. In fact, he is from abroad only. He came for a holiday and showed me then in this test.
Hypothyroidism is not related.
No, in fact, he had hypothyroidism, but that not related because hypothyroid status is perfectly under control. But still, he's got progressive weakness.
So we had a similar case of RYR mutation where the disease was termed as King-Donborough syndrome, sir. The patient can have a congenital myopathy, malignant hyperthermia, so the anesthetic used to be. So we had a similar case, sir. There was also genetic phenotypic discordance, but case reports have been described in this King-Donborough syndrome, sir.
Okay, I did not know that. So they are also present like this slowly progressive myopathy, can present like that?
Yes, sir.
R1R
Yes,
myopathy. Okay.
yes, sir. Our patient was around 20 or 22, sir. His symptoms started at 5 years or 6 years of age, sir.
Now, this patient started at the age of 10, but even after 35, he's still able to walk about. Very slowly progressive. No, I have not seen such case before, only out of curiosity about the patient.
But in literature, it is said that RYR1 has a very wide phenotypic expression. It can be a very
Correct.
yeah.
Right, exactly. That's what they take. So you can go with that. Correct. The thing is that these signs which are described, hip abductions and all, not pathognomonic for anything. When newer and newer myopathies come, that finding will also be there. Okay, then shall we close?
Thank you, sir. Thank you so
Okay,
much.
thank you. Good night.
Thank you, sir. Good night.
Good
Good
night.
night. Thank you, sir. Good night. Good night.
Thank you.
Good night. Good night. Next Wednesday we can meet. Good night, sir. Good night.
Thank you, sir. Good night.
Thank you. Good night. Thank you. Good night.